Tom Bayne. He is a doctor of chiropractic. He's also the president of the Microbiome, and he's done Microbiome Labs, and he's done many lectures for us. He's an excellent lecturer. He's here to answer your Q&A. Do want to remind you, just our disclaimer here, that this is for educational purposes. This is meant to be continuing education. This is not intended to be medical advice. Therefore, do not perceive it as medical advice. If you have a health condition, please do seek out a healthcare provider. This is for educational purposes only. All right, let's sit back and watch this 36-minute lecture. Post your questions in the chat room during this live webinar, and I'll moderate those to Dr. Tom Bayne. All right, let's take it away.
Hello, everybody. I'm Dr. Tom Bayne. Happy to be here at the IFS 2021 symposium. And today we're going to be talking about the microbiome and infertility. So a little bit of statistics on infertility in the US. According to CDC, 15.5% of all women who attempt to become pregnant are infertile. That would mean that they're unable to conceive after 1 year of trying. The percent of married women between the ages of 15 and 49 who have difficulties having multiple pregnancies is up to 16.2%. And the percent of married women between the ages of 15 and 49, the number that are infertile is up almost to 9%. And according to scientists at the Hebrew University of Jerusalem, sperm counts among men in the West more than halved in the last 40 years. Currently, we're falling on average about 1.4% a year, which basically means that the human race is about to become extinct. So what we want to do is we want to take a look at a number of the different factors that are coming in to why there's an increase in infertility. But in particular, in this lecture, we want to focus on the microbiome specifically and its role in infertility. So when we're talking about the microbiome, this is really metaphorically where the rubber hits the road. We're looking at the difference on the left and the right. We're looking at a healthy gut and a leaky gut. And so if we look at the schematic to the left, we see the blue shaded area in the middle there. Looks like a blue colored wave there. And above that is the microbiota. And so the blue is the mucin layer, and it's buffering the microbiota away from the epithelial layer. The epithelial is that caterpillar-looking purple, green, and blue form there. And below the caterpillar, or below the epithelial layer, is the basolateral circulation. And so what happens is we start to see some dysbiosis in the microbiome. We start to see the eroding of the mucin layer. We start to see the microbiome laying and contacting the epithelial surface. We start to see the epithelial cells start to separate, become a little degenerative and inflamed. And then we see poisons and toxins spilling into the basolateral circulation and then being sampled by the immune system. And then we see the reciprocal inflammatory process that comes from that. So go into some more detail on the specifics of this, but to cut to the chase, in order to increase the chances that your patients can get pregnant, we need to be able to correct this issue and the resulting inflammation that comes from it. So let's dive into that. So what is metabolic endotoxemia? Metabolic endotoxemia is a fancy word for leaky gut, but really what it's defined as is an innate immune response. And it's a subclinical, persistent, low-grade inflammation because of increased levels of circulating endotoxins. And the main endotoxin we'll be talking about is LPS, lipopolysaccharide. So it's estimated to affect approximately 33% of the Western population. From our studies, we've seen in healthy populations that number seems to be closer to 55%. It's characterized by an increase in the serum endotoxin, lipopolysaccharide. And it's within the first 5 hours postprandial after a meal. So the first 5 hours after a meal has been consumed, we watch these serum LPS levels increase significantly in the 5 hours after eating. For whatever reason, meals that are high in fat and dense in calories seem to impact the condition more than low fat, low calorie meals. Particularly saturated fat meals tend to get a more exaggerated endotoxic response. So the increase in the endotoxin and it getting into the bloodstream, it's then met with an immune response where we see elevated inflammation that's marked by measurable increases in interleukin-6, interleukin-1 alpha, interferon gamma, triglycerides, postprandial insulin. So this is a process that our body goes through because it's responding as if we're septic. It's responding as if there's bacteria invading the bloodstream. So that's a good short-term response to an emergency situation. But what we're seeing in our Western diet is we're seeing that instead of it being a one-time emergency response, we're seeing it as a low-grade, 3 times a day situation in the average population and in people that are presenting this way. So chronic metabolic endotoxemia and the inflammation associated with it has been shown to have a significant correlation in a variety of diseases, particularly cardiovascular disease, diabetes, obesity, hypogonadism, autoimmune disease, and even mood disorders such as anxiety and depression. We'll look into some of the research on that supports these.
Talking about like population problem might not even be a problem because of how
LPS endotoxin. Okay, so it's an inflammatory immunogen, and the tail is the fatty acid component, and the type of fatty acid that is will give us a clue as to how disruptive the endotoxin will be. So if it's a omega-3 fatty acid that's attached to endotoxin, we get a relatively blunted, low type of inflammatory reaction. But if we have a saturated fat that's attached to the endotoxin, we get a much higher, much stronger endotoxic response. So LPS is a normal part of gram-negative bacteria. It's part of the outer membrane of the gram-negative bacteria. When they die, for whatever reason, so you've got trillions of bacteria in your microbiome, you eat some food, and some of those bacteria die. Some of them die because it was their time to die. Some of them die because there were antibiotics or maybe glyphosate in the food, and they die. But point is, when the bacteria die, they lyse. This is normal. When they lyse, the LPS is released from the membrane and into the lumen of the intestines. So this has been happening forever. This is a normal response to the bacteria that live in our digestive tract. When it becomes abnormal is when the bacteria or the bacterial toxin, the LPS, passes through the epithelial layer. That's when it becomes problematic. And so when we look at the endotoxin, we find them in low levels in healthy people. But what you'll see in the next few slides is when we start to see them in high levels, we start to see disease progressing pretty quickly. So this is just a slide to show you that the type of fat counts. So when we're looking at the increases in endotoxemia as a result of the types of fats being consumed, we see that olive oil is kind of neutral. It doesn't increase or decrease the endotoxemia. We see that fish oils can actually reduce the endotoxic response, but we see saturated fats like coconut oil increasing the endotoxic response. And in fact, when we wanted to test endotoxemia in dogs, the only thing we did was we had 2 groups. We had one group that ate kibble, and the other group ate kibble with coconut oil on it. And we saw a much stronger endotoxic response in the dogs that ate the coconut oil than we did in the ones that just ate the kibble. So again, proof that it's the saturated fat that's going to exacerbate the intensity of the response to the endotoxin. So let's understand a little bit about the immune activation of metabolic endotoxemia. So what you have is you have circulating LPS, and it becomes bound to a transfer protein called LPB, LPS binding protein. And the LPB carries the LPS to the CD14 toll-like receptor complex where it can be examined. So once the LPS-LVP is bound to the CD14 toll-like receptor complex, it initiates this immune cascade that leads to the activation of NF-kappa B. And so the activation of NF-kappa B leads to an increased expression of the pro-inflammatory cytokines, tumor necrosis factor alpha, interleukin-1 beta, interleukin-6, MCP1. So there's a whole slew of inflammatory cytokines that are released in response to the activation of the NF-kappa B. So the innate immune cells that become activated by the LPS cause a chronic release of these pro-inflammatory cytokines. And this exists in all parts of the body, even affects our blood-brain barrier. And so this is the immune activation. This is where it's happening and what's happening in the body in response to LPS breaching the epithelial layer and getting into the basolateral circulation. So let's look at some of the clinical manifestations of LPS and its effect on the immune system. So the metabolic syndrome, all of these conditions here have been associated with elevated levels of LPS in the serum. We'll go through some of the research with each of them, but just look at this list. We got heart disease, lipid problems, hypertension, type 2 diabetes, we got dementia, cancer, polycystic ovary disease, non-alcoholic fatty liver disease. Now, when you look at these things, you might think that they really don't have too much in common. But in reality, what all these conditions have in common is chronic leaky gut and a chronic inflammation associated with the release of the cytokines in response to the LPS being in the bloodstream. It's this low-grade septicemia that the body's responding to. It's responding to it on a daily level, and that chronic activation of the immune system is leading to these chronic degenerative diseases. So here's some of the research supporting that. So this is a very interesting study. It was done by the American Diabetes Association, and it was showing the levels of endotoxins in the 4 hours after a meal. And the group was broken down into four subsets. So you had normal, you had people that were overweight, you had people that were hyperglycemic, and then you had people that were type 2 diabetic. So what we see is that, normal is obviously the lowest, but, hyperglycemic and obese patients, they show elevated LPS compared to normal, but look at type 2 diabetes. So we're talking about a twofold increase from the obese diabetics, right? From the obese and hyperglycemic to the diabetic, we're seeing a twofold increase in LPS. And so the outcome of this study was that the measurement of serum LPS is probably the best marker to be able to tell when somebody's shifting from hyperglycemia to diabetes. That it was the one factor among all the patients that they looked at. It was the one marker that best exemplified whether they were going to tip over into the type 2 diabetes or whether they were just going to stay in that hyperglycemic pre-diabetic state. So here's supporting it in the diabetic. This is a study that showed that high fat intake leads to that postprandial exposure to the endotoxin in diabetics. And so again, they recognize the connection in coronary artery disease, obesity, fatty liver disease, but really diabetics eating saturated fats had much higher concentrations of endotoxins in their blood than those that didn't. So this is a really interesting study. This is some of the newer things, at least in the 25 years I've been seeing patients. I don't remember too many skinny diabetics when I first started practicing, but of late I'm seeing more and more skinny diabetics, especially past the 6th decade of life. We're seeing more and more thinner diabetics. And this study kind of explains a lot of why that is. And so what they've been able to understand is that the LPS from the gut, it creates this inflammatory response it does that throughout the body. And when it's chronic enough that it can get across the blood-brain barrier, it starts to impact the hypothalamus, and it starts to impact insulin production from hypothalamic communication with the body. So what we're actually getting is a dysregulation in blood sugar coming from the brain, because LPS has purged through the barrier of the blood-brain. It's got into the brain, and it's creating an inflammatory immunogenic response in the brain. And so it's a really fascinating study, and really goes far to help us understand how we could have a type 2 diabetic that's not morbidly obese. Here's the connection between obesity and cardiovascular risk. The connection is serum endotoxin, LPS, in the bloodstream, higher levels and being associated with more inflammation and a higher risk of cardiovascular disease. So here's another one of those kind of drop your mouth open kind of studies. So in this study, we've been looking at Alzheimer's patients, and we see these lesions in their brain. And we recognize that the lesion is an immune response, but we really, until this study, we really didn't have an idea of why. Why was there an immune response in the brain leading to these lesions in the Alzheimer's patient? And so what they were able to find, they did some postmortem dissections of Alzheimer's brains, and they actually found that in the lesions in the brain, there was actually gut-derived LPS. So what we're seeing is, again, chronic leaky gut and the LPS building up and crossing over the blood-brain barrier, getting into the perinuclear region, and then potentially it's the immune system that's causing the lesions by trying to get the LPS out of the brain. Perhaps it's the LPS itself creating the inflammation. I think we need more research to find out deeper on the mechanism of how this is working, but to be able to recognize that at the root of the lesion in the brain, there's gut-derived poisons that are in the brain. So really what we're saying is that Alzheimer's disease is nothing more than a chronic leaky gut, or the expression of that chronic leaky gut. So what we've done so far is I've been able to show you that our gut, the microbiome, is very closely associated with chronic low-grade inflammation and the inflammatory cytokine response associated with that. But this is a fertility lecture, so let's get back to fertility, right? So here are studies showing the connection between the inflammatory cytokines and infertility. Now, this study was in endometriosis patients, but in particular, interleukin-6, interleukin-10, interleukin-13, tumor necrosis factor alpha were all associated with high levels of those cytokines were all associated with infertility. And so that's in one study. In this study, they were able to show that follicular pro-inflammatory cytokines and chemokines, they were actually markers of IVF success. So if somebody's coming in for IVF work, and they're looking for, they're going through the process of fertility, and they're wanting to see what the likelihood that this is going to be a success, one of the main markers they look for are inflammatory cytokines. So if you have a tool that can reduce inflammatory cytokines, then that means you actually have a tool that can improve IVF, can improve your patient's outcomes in IVF, right? So these same cytokines that we're seeing in the leaky gut, they're being used as markers of whether or not there's going to be success. Next step would be, let's use something that can reduce these cytokines and chemokines before we do IVF, so that we can ensure a higher rate of success with these patients. So here's a study about cytokines in male infertility. And in particular, this is a second study that showed that cytokines in the male reproductive tract had a major role in male infertility disorders. And so the inflammation becomes local in the male reproductive tract, and it starts to injure those tissues the sperm itself, but also the tissues that are producing the sperm, leading to reduced sperm load and infertility in men. So this is another way that gut-derived LPS, serum endotoxins, are associated with male infertility. And so this is something called the Gelding Theory. And so Gelding actually stands for gut endotoxin leading to a decline in gonadal function. So what they're proposing is that in response to elevated levels of LPS in the blood, the body is actually producing less testosterone. So male obesity has been associated with late onset hypogonadism. It's a condition characterized by decreased serum testosterone, decreased sperm quality, diminished fertility, and quality of life. Okay, that's a fact. So the Gelding theory describes the development of obesity related to hypogonadism. So several observational studies have reported an association between obesity-related hypogonadism or low testosterone. So for the first time, they're postulating that the transmucosal passage of bacterial LPS from the gut lumen into the circulation is a key inflammatory trigger underlying male hypogonadism. How interesting is that? So the endotoxin is known to reduce testosterone production by the testes, thereby also leading to a decline in sperm production. Testosterone is a known powerful immune suppressant. It decreases a man's ability to fight infection. So what they're postulating here in this research is that the male reproductive axis has evolved the capacity to lower testosterone production during times of infection and the resulting endotoxin exposure. So that decreases the immunosuppressive influence of testosterone. So what they're concluding is that the body thinks you're in an infectious state because you're spilling these bacterial waste and bacterial byproducts into the bloodstream. So the immune system is responding. There's an infection, 3-alarm fire. We got to stop the infection. And as part of the process of doing that, it blunts the production of testosterone because testosterone reduces your body's ability to fight infection. It's slightly immunosuppressive. So it's an intelligent thing. And if this were a life or death thing, you would want that temporary suppression of your testosterone in order to be able to fight the infection. However, if you're having endotoxins being spilled 3 times a day and this low-grade inflammation is going on 24/7, 52 weeks a year for years on end, then the body's ability to produce testosterone shuts off. So what's the solution? So we've looked at the microbiome. We've looked at it as a driver of inflammation, a driver of low-grade septicemia and the cytokine response that's produced in response to the LPS in the blood. We looked at that and got an understanding of the microbiome there. We've seen a correlation with fertility in that fertility is frequently associated with elevated cytokine levels. We're also seeing aspects of hormones being disrupted by excessive amounts of LPS in the bloodstream. So what's the solution? Well, we looked at, could we use a probiotic to reduce the amount of circulating endotoxins in a patient's system? And would that result in a reduction in the inflammation associated with that LPS in the bloodstream? So this is a study that was done in 2017. We'll go through some of the details. So what we did is we gave students, healthy college students between the ages of 18 and 33, we gave them a high-fat, high-caloric meal. We gave them a McDonald's breakfast, and we observed what happened in their blood over a 5-hour period after the meal. In pilots of this, we actually watched for 12 hours. We actually saw that one meal for one of these high-fat, high-caloric meals, one of the McDonald's breakfasts, created over 12 hours of disruption to the microbiome, inflammatory disruption, and it took almost 2 days for the microbiome to even start to get back to what it was before the meal. And so hugely disruptive to the microbiome is what these meals are. And so, but what we saw consistently was at the 5-hour mark postprandially, we saw this 5 to 6x spike in LPS. And so this is our model, right? So we've got a model that shows that when we give somebody with LPS levels at the time of eating, they got almost nothing. And 5 hours after, we've increased it 5-fold. This is our model. And so we send these patients home and we say, take this probiotic for 30 days, come back, do the same test again in 30 days. And that's what happened 30 days later. And so we completely blunted the circulating endotoxins. And therefore, we also reduced the inflammatory cytokines. We improved ghrelin, insulin, and glucagon levels. Overall, the body was less inflamed. It managed blood sugar levels healthier. The ability to feel satisfied and full remained for longer, and low-grade inflammation was dramatically reduced. So this was the pilot. We then scaled this up to a double-blind placebo-controlled study, and we showed a 45% reduction in the treatment group. But look at this. We showed a 32% increase in the placebo group. So it was over 60% difference between these two groups. What's interesting is that the placebo group increasing by 32% says to us that this leaky gut thing, this metabolic endotoxemia, is a progressive condition. So right now we're doing the same study in twice as many subjects, and we're doing it over 90 days because we want to see if the separation continues over time. And so that study's ongoing right now. I'll be very excited to share the results with you when it's finished. So this was an interesting finding. We showed a 30% reduction in triglyceride levels in patients who didn't have elevated triglycerides. And so we need more research to understand exactly why this happens, but I think a really intelligent thought around this would be clearly when LPS is spilling into the bloodstream, it's putting a huge amount of stress on the liver. So that stress that the liver is trying to pull out all that extra LPS out of the bloodstream creates inflammation in the liver. When you've got inflammation in the liver, you get an increase in triglyceride production. Take the stress that's coming from the gut, the LPS that's being spilled into the circulation, take that out of the picture, and the liver can relax. The liver is not as inflamed, it's not as irritated, so it doesn't make as much of the triglycerides as it would otherwise do when it was in a stressful situation. So very interesting. We've since done this study in patients with elevated triglycerides, and we showed the same 30% reduction in those patients. So a very interesting way of addressing elevated triglycerides by reducing the amount of LPS that's spilling from the gut into the bloodstream. This is one of the inflammatory markers, the MCP1, and we were able to show a significant reduction in LPS, in MCP1 when we were able to blunt the spilling of the LPS into the bloodstream. So again, we're showing that we can reduce these inflammatory cytokines that we've already shown are associated with both male and female infertility. So this is a hot map. And so if you've never read a hot map, I'll help you. The middle line, the black line between IL-8 and glucose, so everything below that line didn't meet statistical relevance. We could still see patterns. We could still see patterns of improvement below the line, but we just didn't have a big enough group or enough time for those different measures to be statistically significant. Above the line, everything is statistically relevant. And so we showed statistically relevant reductions in endotoxins, triglycerides, ghrelin, and all of these inflammatory cytokines. We're confident one of the other reasons we're doing the next study for a longer period of time and in a larger population is because we feel if we just can get enough data together that a lot of these inflammatory cytokines that are below that line will bump up above and become statistically relevant. So this is a very interesting shift that we see. So on the right, you have all the patients that are taking the placebo. Look at all the orange, reds, it's fire hot. To the left are all the patients that were taking the probiotics. It's where we see yellows and greens. And so there's a huge difference here in the amount of inflammation from one group to the next. And the only difference was that they took 30 days of spore-based probiotics. So in conclusion, intestinal permeability, metabolic endotoxemia, leaky gut, it's the #1 cause of morbidity and mortality worldwide. It leads to conditions like obesity, heart disease, autoimmune disease, diabetes, hypogonadism, Alzheimer's. If you're wondering if metabolic endotoxemia is associated with the disease that you're focused on in the moment, just Google the both of them. Google metabolic endotoxemia and rheumatoid arthritis and see the reams of studies that will come out and show you the connection between the two. Every autoimmune disease that we've studied so far the researchers are at a tipping point where if they can't find something to reduce the LPS, they can't get their research to go any further. They need a tool that reduces the cytokine inflammation associated with the spilling of LPS into the gut. And so we've talked to researchers with Hashimoto's, scleroderma, rheumatoid arthritis, because all these researchers have already made the connection that this LPS-derived cytokine response is what's driving their autoimmune disease that they're studying. And so this immediately becomes the most important probiotic that you can give to these types of patients. If you've got an autoimmune disease patient, the only probiotic that's shown any relevance to that community is Megaspore. It's the only product that's been studied to be able to reduce the inflammation of those conditions. So metabolic endotoxemia is a feature of a dysbiotic gut. That's how it starts. The dysbiosis is the initial change in the microbiome that leads to the leaky gut. It affects the immune system as well as the endocrine system. Hallmarks are high serum LPS and LBP. It's easier to measure LBP in the clinical setting. For those of you with your slant on how you want to deal with this with your patient. Testing serum LPS in a clinical situation, it's really not cost or time effective. It's very inconvenient for the patient. But measuring LBP is something that you can do in the clinical setting, and it is very relevant. So hallmarks of this are high LPS and LBP, elevated interleukins like interleukin 6, interleukin 1 beta, elevated triglycerides, postprandial insulin, all elevated. So Megaspore significantly reduces postprandial endotoxemia, interleukin 6, interleukin 1 beta, elevated triglycerides, and no dietary changes or other therapies were done here.
Team, we just lost the video. I want to know if that's in the video or is that us? You're going to finish this last 3 minutes. But hit pause again, though, before you do that. Because, Tom, when we get to your Q&A, one thing I'm excited about that I just heard is so I can eat my fast food once in a while and take your product because you said no dietary changes. I don't know if I'm going to tell that to my patients, mind you. Yeah. but I did like what I did hear that. Team, I noticed something got shared here that's not part of the video. So can Lorianne or somebody just fix that? We got 3 minutes to go on this video, and we got something.
This was something that happened while I was recording.
Oh, this is you? Okay. We missed that then. All right. So we'll just continue to play, and this will move out of its way.
A little bit. It'll come back.
Okay. And then we'll do so, guys, keep posting your Q&A. I got a few texts to me that I put into our Q&A and put them in the chat as well. And we got some questions for you coming up in a second. Go ahead and hit play again, team.
So, sorry about this. I don't know what happened to my computer, but okay. So let's just finish this up. Bacillus endospores reduce ghrelin and trending towards a change in leptin. So what we're seeing is that, you know, you're not as hungry. When someone was eating a 2,000 calorie McDonald's breakfast meal, an hour and a half later, their body was still hungry. Their brain was hungry. There was no nutrition in the meal. So we understand why their brain was hungry. But the disconnection between their gut and their brain, so their brain's telling their gut it needs to eat again, and the gut's saying, yeah, but I've got 2,000 calories in here. I can't eat right now. And so that disconnect causes people to continue to eat when they're more than full. And so what we were able to see is that adding the spores in, it started to get that connection between the gut and brain working again. So we were able to see that it significantly increased certain keystone bacteria in the microbiome and increased the diversity of the microbiome. So when we're talking about infertility, and we talk about all the different tools, you know, it's an infertility symposium, you know, there's lots of different tools that are used to help support patients who are having challenges getting pregnant. And I'm not here to discount any of them. What I am here to talk about is the need to address the microbiome when you are addressing infertility. If you are not addressing the microbiome when you're addressing infertility, you are doing a huge injustice to your patients. You are not reducing the inflammatory cytokines that are at the root of why their body is not allowing them to get pregnant in the first place. So that concludes our lecture for today. I want to thank you for your time. Thank you for listening. And please, if you have any questions, please send them off to the IFS crowd, and they'll put them off to me and I'll get them answered. I know we're doing a live Q&A coming up too, so I'll be happy to answer any questions from either of the lectures that I did. I want to thank Lauren and his group for having me and allowing Microbiome Labs to sponsor our lectures here for this talks. And hopefully next year we can get together in person and share our experiences together. Thank you again.
All right, perfect. So big thanks to Tom for creating that lecture. We're going to do some Q&A. I just want to remind you on the IFS website, this lecture and the immunity lecture are both available, so you can watch this again. And if you want the handouts for either of those, do contact Microbiome Labs directly on this page. The Q&A that we did for the immunity talks there, and we'll post the Q&A from this talk there as well. And they have a special as well, so Tom may mention what that is, but it's on the page here. And if you go into the forums for the IFS, for those that are part of it, you can continue this discussion as well. So I just wanted to let you guys know that. All right, so I got a couple of questions for you coming up, Tom. So one is around the fats, because you're talking about the coconut oil. It looked like it didn't look so good having that fat there because of the endotoxemia. The question is, if you need more regarding fats, is there evidence that proper quality saturated fats, hydrogenated margarine, are more damaging than, poor quality saturated fats, hydrogenated margarine, are more damaging than high quality saturated fats as far as the endotoxin response goes? Because in the realm of fertility, high quality saturated fats are frequently recommended to support hormonal production, blood sugar regulation, etc. So the question is, these high quality saturated fats are often recommended but there was a concern about this endotoxemia. So was there a differentiation between poor quality and high quality?
So we've not seen any of that in the research. It's just been straight up as far as they've checked vegetable oils, they've checked, coconut oils, fish oils, things like that. So there wasn't a breakdown within the saturated fats as to was one type of saturated fat worse than the other. Here's the point. I don't think that, I really don't think it's healthy for any human, particularly a human that is trying to create another human, to completely not eat saturated fats. That's not what we're saying. And like it's been pointed out on multiple occasions, there are reasons why certain saturated fats would be beneficial. So you have to take everything with a grain of salt, right? I'm not here telling you what to do and what not to do, right? What I'm saying is, if you're making recommendations towards saturated fats, and the reasoning being that it's healthy for hormone balance, and this particular patient in front of you requires that type of attention, then you do that. But while you're doing it, you protect their microbiome. Right? That's my point. And so I'm not here to be the guy who's against saturated fats. That's not what I'm trying to communicate. What I'm saying is that when we want to get an exaggerated response, when we really want to be able to see that inflammatory reaction, the saturated fats create a larger endotoxic response than any of the other fats. Now, why that is, I don't really know. We would have to get some more scientists involved. I'm just taking the information that I have. I hope in 5 years when we do this conversation, I'll be able to take the information we have, and there'll be more research that'll tell us why. But I don't have the why right now. I just know that, in particular, when you've got a person who is sick, I mean, we talk about a lot of conditions here, right? We're not just talking about infertility. We're talking about a lot of people who are sick. Now, when you've got those people, you really got to be careful with the saturated fats, and you have to protect them. Now, in the case of the infertility patient, they're not necessarily sick, but it would appear that they're still expressing a lot of inflammation. And so how do we manage that? Well, if you're going to use the saturated fats for other reasons, other legitimate reasons that are necessary, then you have to protect the microbiome. It's just that simple.
And then there's a question about the microbiome of babies born via C-section. Can the Megaspore, the microbiome product, be used in babies, or what's the age that somebody would start using this product in children born via C-section?
So I have an interesting case study that I'm very excited to share with everyone. But basically what happened was, we had a healthy woman who's 9 months pregnant, and we took a sample of her vaginal microbiome right before she went into labor. She went into labor, baby twisted, cord got around the neck. They had to do an emergency C-section. We took a sample of her amniotic fluid, and then we took baby's first stool. And what you see is that the bacteria in baby's stool looks a lot more like the bacteria on the doctor's hands than it did mom's microbiome. What you saw in the amniotic fluid was this beautiful, pristine environment that was attempting to seed baby's microbiome via the amniotic fluid. And it was seeding it with the bacteria that are very good at digesting milk carbohydrates, right? So very specific. So the baby's microbiome is very specific, and it's meant to help that baby digest breast milk, right? That's what this is all about. So this C-section baby didn't have the balance of those bacteria right away. And so what we're now able to show is then by supplementing with the Megaspore, and how we did that is we have mom open up the capsule, and as she's putting baby on the breast, I would put her finger in a little bit of powder, get a little bit of powder on her hand, on her fingertip, put it in the baby's mouth, and put baby on the breast, and feed the baby. And do that, every other meal, every third feeding, whatever it might be, but just try to get a steady state of the spores going in so that they can recondition the microbiome. So a lot of what we're talking about here is priming in the baby, in the infant, in the newborn, is priming the microbiome to receive the probiotics from the breast milk. There's over 600 bacteria that we know of in mother's breast milk. So it's this combination of early bacteria that help your body digest the milk carbohydrates and milk sugars, and then taking in the probiotics themselves from the breast milk. And so the infant or the newborn's microbiome is very simple compared to the adult microbiome. It's not very diverse, but it's very specific, and it's got a specific role that it needs to accomplish in order for this infant to get to the next level where it can have more of an adult-like microbiome. So what we've been able to show, though, and this is just a one case study, but we've been able to show that using the spores reconditions, gets rid of those bacteria that aren't supposed to be in the microbiome. You're not supposed to have hand bacteria in your microbiome, right? That's not supposed to be there. And so by reconditioning the microbiome, getting rid of those pathogens that aren't supposed to be there, creating an environment that's conducive for the short chain fatty acid bacteria to start producing and creating that acidic environment in the large intestine, that's our goal. So the story is, yes, you can recondition the microbiome of the C-section baby, and my advice is to get started immediately. Get started with that first feeding as soon as possible, to get the spores in there so that we start getting some balance. The hard part is that when you talk about probiotics, a lot of people still hold on to this idea that I need to eat the probiotics so I can go live in my gut and live happily ever after. And that is just not supported by science. And I spend so much of my day trying to break down people's old belief systems about what this is about. We're not trying to get the bacteria that were in mom's vagina into baby's mouth. It's too late. We missed that boat, sailed, right? That's not the plan. The plan is get rid of the pathogens, create a calm, non-inflamed state in the microbiome so that baby can digest the food that's coming in and take on the new probiotics that are coming in that are more representative of the adult microbiome. So that's the plan. It's really hard when people are stuck on that thought of, I'm missing X, so I have to take X. And that's not what it's about.
A follow-up to that then is, right now in the fertility world, they're testing the uterine environment. They're doing endometrial biopsies, checking the microbiome, and often they're treating with vaginal suppository probiotics. So based on your understanding, does it need to be vaginally? Can you still do it orally, these pills? Do you do both? What's your theoretical thought or any research you're aware of?
So when you're talking about reducing the systemic inflammation associated with the problem, it's the oral spores that are doing that. When you're talking about the vaginal suppository probiotics, you're basically, there's 7 strains of lactobacilli that live in the vaginal microbiome, right? So it's not a very diverse place. It's actually very simple to see a healthy vaginal microbiome. It's very basic, and so. And what you get with that is you get these bacteria that are producing, they're lactobacilli, they're producing lactic acid. And so the vaginal environment is very acidic because that prevents yeast, it prevents pathogenic bacteria from taking root in the vaginal microbiome. And so when you're talking about a vaginal suppository, basically it's the same thing as putting lactic acid in it. Those bacteria are not living in the vaginal microbiome. It doesn't work that way. But you are getting the dead DNA from those bacteria, the lactic acid that they've produced. You're getting symptomatic changes to the microbiome. And so, it's the same thing like somebody who's got a chronic yeast infection who uses boric acid, right, as a supplement, right? All you're doing is changing the environment with the hope that the immune system will kick up, and then your immune system will get rid of the pathogens. And so with the vaginal suppositories, that's the same thing. You're getting symptom treatment. You're not changing the environment except that short-term acidic change that you're getting with those bacteria. So again, Is there something wrong with using those bacteria? Absolutely not. But you're not long term. You're not changing that vaginal microbiome. That's going to require a systemic change. It's going to require a longer period of time. But using the suppository to manage the symptoms, to give you a temporary balance in that microbiome, in the vaginal microbiome, is definitely a smart move, but definitely clinically an intelligent thing to do. It's just understanding what you're doing, what you're not doing, right? You're not changing the vaginal microbiome by using that suppository. You're giving yourself a temporary change in the pH of that environment. So that's what it gives you. Can be very effective for some people, especially when the pH is just a little bit out of whack. It'll restore it really quickly, and their symptoms seem to go away. Now, they have to continue to use it in order to maintain that. So long term, to recondition the entire vaginal microbiome requires you to balance your gut microbiome. And so that's a long-term thing. And so when you run into these patients, you can't say, well, I'm going to need 9 months to correct your gut microbiome before we can start talking about your vaginal microbiome. It doesn't work that way. You've got to be able to do these things in tandem. And that's where the vaginal suppositories are helpful, because it allows you to get some vaginal relief while you're making the changes to the intestinal microbiome.
And then there's a question about the stability of the product, since it's not required for refrigeration. How stable is the product since you're not refrigerating it?
And what's funny is I would ask that question to companies that have to have refrigerated probiotics. If you've got a refrigerated probiotic, how does it survive 98.6 degrees and a pH of 1.3? So the joke here, again, we have to break down what people think. We've been marketed to, we've not been sold science, we've been marketed to, but we've adopted these things as science. And I, for one, I led the class. I'm the one who said, this is fact, ma'am. This Lactobacillus acidophilus is the primary bacteria of your gut, and you need to supplement it every day. I didn't know that Lactobacillus only makes up 1% of the gut microbiome, right? If we were actually doing what we think we were doing with these refrigerated probiotics, we would be creating redundancy in the microbiome. The refrigerated probiotics are the most unstable of the probiotics, right? If they're not refrigerated, they die. Well, how does that exist? Where did caveman get refrigerated probiotics? Right? How did we get this far without refrigeration? Right? So it doesn't make sense. But I, like all of you, like many people, swallowed the marketing and believed it to be true that, well, only the best probiotics are in the refrigerated section. A truly stable probiotic is shelf stable. A truly stable probiotic can be cooked at 250 degrees, can be frozen without any problems, because it can survive in many different environments. Spores fit that description better than any other probiotic. So from a stability standpoint, I would say the only probiotics that are stable are spores. All the others, they should have to prove to us that they're stable, but they don't. They just make up things like, oh, well, the refrigerated ones are the most stable. No science. Never been a study showing that the ones that are in the refrigerator are more stable. That's marketing. And the person who invented that marketing thing's probably living on a beach somewhere, not working real hard right now, because many of us adopted that as fact. But follow the science. Refrigerated probiotics are the most unstable probiotics. And let's have the people that are selling those products prove to us that they are stable. They don't. They can't do it. There's no science supporting it.
All right, some more questions for you. We're going back to the fat question, because I think in the paper, coconut oil, which we're considering a high quality saturated fat, it looked like it had a negative impact when you're looking at endotoxemia. So the question is, but is the rise of the endotoxemia response with saturated fats, was that in the sick person, or will a normal person get the same response to endotoxins?
In the leaky gut study that we published, anybody that had any conditions, any diagnosable conditions, we excluded them from the study. These were 18 to 30-year-old healthy patients. And we saw a 55% incidence of leaky gut or endotoxemia in those patients who were healthy. We're not talking about sick people here. This is only studies that are being done in healthy adults. When we start doing the studies in sick patients, instead of it being a 5 to 6x spike in endotoxemia, like in the diabetics, it's a 10 to 15x spike in endotoxins, right? So what the conversation we've been having to this point is, hey, this is associated with all these diseases, but the studies that we're doing them in healthy patients, because in the unhealthy, the numbers are too skewed and we can't make any sense of them. So we try to bring it down to a level where we can see the differences among patients and get some kind of baseline. In sick patients, they were all over the place, much higher than what it was, but no consistency from one patient to the next. That's why we used healthy patients for the studies.
Another question is with the practitioners that are seeing their patients for fertility or almost like asymptomatic. So they don't have these outwardly digestive issues or skin issues, but let's say fertility issues, sperm quality doesn't look great. We're seeing some changes here, low testosterone. Sometimes people need some testing to see that there is a microbiome issue or endotoxin issue. You talk about some of these testing, some of the like LBP. What would clinicians be testing then, or you're recommending to educate patients to let them know they have something imbalanced so they would benefit from treating these areas or taking care of these areas? Is there a certain microbiome test you like? And what are some of the labs that you would be thinking about if you're working on fertility patients that are having issues getting pregnant and there's nothing overtly been diagnosed yet?
So there's a number of labs out there that will do like a zonulin testing, and they'll look at these types of markers. And really what they're looking at is they're looking at antibodies towards zonulin. Okay. Now, if you have elevated antibodies towards zonulin, then you have a chronic leaky gut, and it's significant, and it's going to require years of treatment to get it back into balance. But if that test comes back negative, it means absolutely nothing, right? So it's a relevant test if it's elevated, but if it's negative or low, it means zero. All it means is that you haven't developed the immune response yet. It doesn't mean it's not there. It doesn't mean you don't have endotoxemia, right? When we finished the first study, my first question to the researcher was, oh my God, we've got the perfect test for the clinical environment. We can do this test and we can all see the patients that are impacted by endotoxemia. Here's the problem. Those patients had to eat a McDonald's breakfast, and then they had to sit in the lab for 5 hours having blood drawn out of them every hour. So clearly it's not for the, for the clinical setting, right? So what we've looked at then is, LBP, that's a simple blood test, whether LabCorp, Quest, whatever, you can order serum LBP. If that's elevated, then there's been a lot of LPS in the system to try to bind to that LPS to get it out of the body. So it's cheap and it's an easy test to run. When we're talking about the microbiome itself, that's been a whole nother problem for us, right? So people are coming to us over the past few years and they're like, here, this test here says that this, that, and that are high and this is low. Here's the problem. Most of the tests, almost all of the tests that monitor the microbiome in the professional space in North America are done with a technology called 16S ribosomal testing. That form of testing is not sensitive enough to give you the information they claim to be giving you, right? So it's saying, oh, your lactobacilli is low, but it's not strong enough to tell you. It can't go down to the species level and see that your lactobacilli is actually low. So there's a 30% swing on both sides. So in honesty, you could put all the bacteria in your microbiome on a board, and I could take darts and throw it at the board and probably get closer to what's going on in your microbiome than those tests. And because of that, we had to go in and we had to create a test. So the Biome Effects test is a test that we had to create in response to the garbage that's in the North American microbiome testing market. And we had to do it because the technology for 16S is dirt cheap. So they could charge $600 for a test. Their cost is like less than 30. And so they can market the hell out of it. They can spend thousands of dollars on marketing to get you to believe that their test is effective so that you'll use it because they've got such huge profit margins. The technology, the gold standard for evaluating the microbiome is full shotgun metagenomic sequencing. That's a very expensive technology, and it's one that none of the other companies are using because they can't increase their margin 10x in order to afford all the marketing for you. So we're not the last thing I want to do is get into stool testing. I felt like my hand was forced because I was continually having to answer questions about these stupid tests where the information is not valid, and people were having a hard time understanding that. So the Biome Effects test, that's one. And there's another test that's done by Thorne. I can't remember the name of the one, Longevity. So Longevity and Biome Effects are the only two full shotgun metagenomic sequencing tests in the professional space in North America. If you're not using one of those two tests, you're wasting your patient's money and your time. And so if we were looking at, trying to establish data showing the patient that this leaky gut thing is an issue for you, and it's disrupting your microbiome, it's disrupting your immune response. If we're looking to accomplish that, then the best thing you can do right now is the serum LBP testing and the Biome Effects or Longevity full shotgun metagenomic sequencing. With the Biome Effects test, what we've been able to do is we've been able to make it more functionally relevant, right? So we look at ratios of bacteria to each other. We look at a number of different components, the different pathogens, the different keystone species. We look at that and we create treatment plans around that. So that's the difference with the Biome Effects test. We've tried to make it more user-friendly and more relevant to the practitioner. Now, if we were just a stool testing company, we'd have to charge $1,500 for the test. So we don't lose money on the Biome Effects test, right? We just get it out for what it costs us to do it. And because we want doctors to have relevant information that they can use for their patients. And so from my perspective, if you're doing full shotgun metagenomic sequencing for the stool analysis and you're doing the LBP testing, that combination of information really lets you know that the patient is having problems with this leaky gut issue or this endotoxemia, and it's disrupting their microbiome to what degree and what things do you need to do to correct that.
Question about taking the product long term. Does it shift the balance in a negative way? So some patients, they're being treated holistically and they come in with skin issues, whether it's fertility or immunity issues, headaches, dysbiosis, and they start to get relief and they feel great. But now they don't want to stop the product because they feel so good. Is it just basically you're just spending money, but you maybe not be benefiting, or can you actually keep taking this and shift to a negative balance and cause other issues?
Yeah, there's no negative issues that happen. What the thing is that, right, we're eating every day, right? And so the process of this is what a lot of people don't want to accept, but the act of eating promotes inflammation. Now, it's only supposed to promote inflammation on a very low scale. It's supposed to not even reach the basolateral circulation. And the foods you eat can create a more inflammatory response by your choices. Kale salad is going to be much less inflammatory than a cheeseburger and fries. So those are some obvious things, but nonetheless, we can document that and we can show that. So the spores are transient. They're in your body for 21 to 28 days. So once you've been taking the product for a month and you continue to take it, then you're adding a little bit every day and a little bit's leaving every day. And so you create this steady state and you're controlling the inflammation associated with eating. So when I have in the lecture, we talked about cardiovascular disease, diabetes, and autoimmune disease, all that. When I see those level of patients, I basically tell them, look, this is yours for life. You're going to need to take this probiotic for life. And I'm straight up with them because that's what it is. Now I'll say to them, you can maybe take a week off here or there. You're feeling good. You can, you're on vacation. Don't worry about it, and then come back and start it up again. But this is yours for life because you have a predisposition to these diseases and you're already down the path. So we can control it, but we can't take our eye off the ball. Otherwise it's going to come right back. And it's not like, oh, I had this infection, I no longer have the infection, so I don't have to worry about it again. It's like, this is eating, and we're all eating. Until we can figure out how to function without eating, you need protection from eating. So I think that there's not a concern with taking it every day, but let's do the flip side now. Young, healthy woman comes in having fertility issues, 0 signs and symptoms of anything other than not being able to get pregnant. So I still would take the same approach. I still feel that there's unresolved inflammation that's driving her infertility. And once she gets pregnant, we follow her through the pregnancy. Then after that, then I might say, I think because you're not really expressing any other symptoms or any problems with your digestion or anything like that, I'd like to go to a maintenance level with you. So maintenance dosing for the spores is to take a full daily dose 2-3 times a week. I like to have people take it on the weekend. Take your spores Saturday and Sunday night, Friday, Saturday night, Friday, Saturday, Sunday night, whatever it might be. But take it the same dose, the full daily dose, but take it weekly instead of daily. And so I would do that. I do that with my healthier patients or my patients who say that they don't have any symptoms. I'll go down to that maintenance level to try to, extend how long a bottle lasts so it's not as expensive for them. It's not my job to save people money. It's my job to keep them healthy. But at the same time, I do recognize that you have to be able to, have rapport with patients. And if somebody's not feeling anything and they don't have any symptoms, they're going to have a hard time continuing to take a full regimen of products after they've accomplished their goal. So I do have conversations with people like that where I take them down to a maintenance level and we supplement it weekly or bi-weekly instead of daily.
There was a question for clarification. When you were talking about the testing earlier, were you saying BioFX regarding the testing?
Biome effects. That's on the Microbiome Labs website. It's one of our offerings. It's Biome, Biome, F/X.
Okay. And then one of the participants does a lot of practice in the GI issue area, and they wanted to know your thoughts about your microbiome test and how it reflects the conditions of the small bowel. Do you feel the megaspore changes more the small bowel microbiome like in Sibo, or is changing the colon microbiome?
So this is a long answer, but I'll try to rip it out quick. So as the spores go through the digestive tract, they change form. So in spore form, goes past through the stomach, gets into the upper part of small intestine, goes into vegetative state, starts to recondition, get rid of pathogens, starts reconditioning the microbiome. Gets into the lower part of the small intestine and it resporulates. We don't know why this is, but we know that the action of them resporulating triggers the Peyer's patches and the gall to have a systemic immune response, a positive systemic immune response. Once it gets into the colon, once it gets through the ileocecal valve and into the ascending colon, it goes back into vegetative state and starts to police the microbiome. So what you have is a product that has an impact in all parts of the digestive tract, from small intestine through to the anus, all the way through. It's changing that microbiome. But the competitive exclusion aspect of the spores is not happening in the lower part of the small intestine. We know that. It's not happening there because it's back in spore form. It's good for it to be in spore form because we need that immune benefit, but we're not getting the competitive exclusion. And that's why in our Sibo protocols, we do recommend that you continue to use natural antimicrobials. I tend to focus on oregano and some, I use biocidin a lot. I probably have 5 or 6 antimicrobial products that I kind of dance around with and use in my Sibo patients. So Megaspore is the best probiotic you can use for Sibo. It does not trigger a histamine reaction, and it's the strongest competitive excluder. But in the Sibo, where it's your own beneficial bacteria backing up from the large intestine and the small intestine, you still need antimicrobials in the small intestine to get that benefit. Now, when we do the Biome effects test, we see the metabolites that are coming out and we see what's happening. And based on what we're reading, we can tell whether that dysfunction is in the small intestine or in the large intestine. It is correct that the bulk of the information we're getting from a stool test is on the large colon, because that's where most of the bacteria are, right? There's, what was it? 1 millimeter by 1 millimeter square biopsy of the large intestine contains 2 billion bacteria. That same biopsy in the small intestine has 10,000 bacteria, right? So it's a huge difference, right? So of course, the more information is going to come from the large intestine. But that said, if there's a problem in the small intestine, if there's some type of an imbalance going on in the small intestine, we can still see it. It's just, the hard part is, and I think when people ask this question, they're asking about Sibo. And the answer to that is, if you have the type of Sibo where you swallow the bacteria and that nasty bacteria is now living in your small intestine, the spores will get rid of that 100% of the time. Now, the problem is that type of Sibo happens probably once in a lifetime for a practitioner. It's a very rare type of small intestine bacterial overgrowth. The most common type of small intestine bacterial overgrowth is when your own beneficial bacteria are creeped up into the lower part of the small intestine. So on a stool test, that doesn't look any different, right? It's the same bacteria, it's making the same waste products, it's just in the wrong location. So a stool test isn't a very good option for diagnosing that type of imbalance in the small intestine. But other types of imbalances, we pick it up in the testing. But there's more going on in the large intestine.
Right, back to some specific reproductive questions, and then we'll wrap up. We've gone over, but it's always interesting to get you on, Tom, and ask you some questions. They want to know if there's any research on the effects of the microbiome products on the vaginal, uterine, or seminal microbiome, given that they're important in the conception and pregnancy outcomes. I think you shared some slides on that research, right? This might have come in before you share those slides. Right. So anything to add to that?
The data we have is on the inflammatory markers. That's the data we have. We don't have data on the changes in seminal quality and things. We don't have that. But we have specific studies where we show reductions in the markers and the markers that are associated with those problems. We've been trying very hard and long to get a specific fertility type study where we can actually say, here were 10 people here 20 people who had fertility issues. These 10 did the normal route. These 10 did the normal route plus, total gut restoration. We pushed that into 3 or 4 different research organizations already, and we're just having a hard time finding a PI that wants to oversee that and do that study. So we're working on it. I'm trying to get more specific information so that we can actually say that. But what I'm very confident saying is, here are the inflammatory markers associated with those dysfunctions, whatever the ones she was speaking of. And these are the inflammatory markers associated with it. And here's what we can do to reduce those inflammatory markers.
And then our last question, I'll remind you guys, as I asked this last question, that if you want the handouts, because there's a lot of studies that were mentioned for the fertility talk, this one, contact Microbiome Labs. And then if you have a chance to watch the one on immunity, he even talks a little bit about the whole COVID relationship as well and cytokine storms. You can also contact Microbiome Labs for those handouts. And let them know that you're part of the IFS. Anybody that's here today, if you want their discount, so contact them that way as well, and they can let you know what's available to you. last question is, they want to know what kind of products that support correct the oral microbiome. So you may have these, and they're looking at the oral microbiome in that there has been some discussion that there's a resemblance to the placental microbiome in pregnancy. So they're wondering your thoughts on that.
The oral microbiome. We're right now we're working with oral microbiome, as you say, a connection to placenta. We're looking at oral microbiome as its connection to heart cardiovascular disease. We're looking at oral microbiome and its relationship to Alzheimer's. I mean, it's huge. We're simultaneously working on a test to monitor it so we can test the oral microbiome and see what dysfunctions are there. So we're working on that. We hope to have that sometime, I think mid-year next year. We'd be looking at having a test where we can monitor the oral microbiome. It's so difficult right now for us to just say, this is the bacteria that needs to be in your mouth. And, you know, I think it's easy to say, these are the pathogens and we need to get rid of them. And I think we're learning more about the oral microbiome but we're just so fresh in it right now that there's just, I wish I could give you guys more on this and say, oh, hey, here's XYZ, here's all the products that fit in with it. We're working on it. We're really blazing a trail with it because there's just enough information to be dangerous without taking it to the next step and understanding the why. But we have a phenomenal research team in Copenhagen specifically working on the oral microbiome. We've got a enzyme product that is working on the plaque of the teeth and getting rid of the plaque. And it was something that was noticed happenstance that it improved the plaque that was building up on the teeth. But actually what the enzyme is doing is it's actually killing the bacteria associated with that plaque and then cleaving the plaque off itself. So there was an actual antimicrobial component to the enzyme too. So we're doing a lot of that research right now and you know, dotting our I's and crossing our T's before we launch the products to correct the oral microbiome imbalances. What I would say is that I'm a big fan of biobotanical research and the work that they've been doing with the oral microbiome. The one issue I have is, you know, constantly having an antimicrobial in your mouth is not a good idea either. But from a therapeutic perspective, if you got somebody that got a lot of halitosis or you've identified that the dysfunction's in their mouth, then utilizing those products from biobotanical research to get rid of the pathogens in the mouth. I think I'm very comfortable at this point having a conversation with docs about removing pathogens from the mouth. I'm not comfortable yet saying this is how we restore the microbial balance. I think when you get rid of the pathogens, you give the beneficials an opportunity to grow back. You know, that's an obvious point, but I think that I would love to answer this question in 6 to 12 months because I think I'll have more data, I'll have more experience, and I'll have more opportunities with patients to see, you know, what's effective, what's not, and be able to answer that question then. So,
well, you heard it here. Then Tom's going to come back in a year, and we're going to have this talk.
Yeah. Short answer is, if you've identified the mouth as a stress, it's got to be because there's a pathogen, and getting rid of the pathogens with the biobotanical research products is your best bet. After that, will their oral microbiome just restore when you get rid of the pathogens? A percentage of them will. Other ones, you may have to keep coming back to the antimicrobials until we figure it out and can offer you something different.
I want to thank you, Tom, and the Microbiome Labs for sponsoring the talk. We're so excited that for the IFS, our sponsors have stepped forward to educate. So letting us not just saying buy our product, but you're giving us some education, and that you guys have been doing some research to support your products. So thank you very much. Thank you guys for joining in. And as you know, the sponsor talks are open to everybody. And so everybody's here, not just people from the IFS. If you're part of the IFS, remember to get in there and finish off your continuing education lectures. Remember, you have those public educational free videos that you can share. And if you're not part of the IFS, you can go to Healthy Seminars, and the courses from the IFS are available a la carte. And one more time to let you know, if you want to have those handouts to reference those studies, to review this talk, you can go to the sponsor page on the Microbiome Labs sponsor page and watch the videos again, or you can go contact them directly because they have those videos as well, and they have those handouts. Contact Microbiome Labs directly, and they'll be happy to share those handouts for you guys. Thank you very much. Tom, thank you again.
Thank you, Lauren. Appreciate you and all you do. Thanks a lot. See you soon.